Today we are discussing a case of a 17-year-old male patient. He's a type 1 diabetic mellitus patient, and he came to the casualty with symptoms of vomiting, drowsiness, abdominal pain, and lethargy. So we have to take the patient is type 1 diabetic mellitus patient. So we took the blood glucose level, and it is around 350 milligram per deciliter. After that, we took the arterial blood gas ABG, and we saw the levels. So the pH of the patient is around 7.24. Serum sodium is around 130 milliequivalent per liter. Serum potassium is around 3 milliequivalent per liter. Serum chloride is around 88 milliequivalent per liter. Serum bicarbonate is around 14 milliequivalent per liter. And the BP of the patient is around 90/60. And IV fluids are rushed to the patient. So again, we will sum up the case once more. So it is a 17-year-old type 1 diabetic mellitus patient. His blood glucose level is 350 milligram per deciliter, and he is having the symptoms of vomiting, drowsiness, abdominal pain, and lethargy. His BP is around 90/60, and IV fluids are rushed to the patient, and ABG is taken, and in ABG we see the pH is around 7.24. Serum sodium is around 130 milliequivalent per liter. Serum chloride is around 88 milliequivalent per liter. Serum bicarbonate is around 14 milliequivalent per liter. Serum potassium is around 3 milliequivalent per liter. So what is the next step we are going to do in this patient? So when we are seeing the case, we can see that by the symptoms like vomiting, abdominal pain, lethargy, drowsiness, and the patient is a known case of type 1 diabetic mellitus, we can conclude that this is a diabetic ketoacidosis case. And from the ABG, we can see that the pH is around 7.24, and the serum bicarbonate is around 14 milliequivalent per liter. So this is a typical case of metabolic acidosis. So diabetic ketoacidosis is there, metabolic acidosis is there, and when we look at the serum potassium level, it is around 3 milliequivalent per liter. So hypokalemia is there. In DKA, in diabetic ketoacidosis, this metabolic disturbances like hypokalemia is common. So as the hypokalemia is present, before giving insulin, we have to correct the hypokalemia, because in DKA, through urine the potassiums are lost, and if you are giving the insulin before correcting the hypokalemia, it will exacerbate the hypokalemia of the patient, as the insulin have the property of transferring the potassium from the extracellular space to the intracellular space. So first, we have to correct the hypokalemia by giving IV potassium KCl, by giving IV KCl. Then we will give IV insulin after correcting the hypokalemia. Thank you.